I just would like to, this is Mila Kostic. I'm the chair of the program committee for SACME. And on behalf of the program committee and SACME, I'd like to welcome everybody on this call today and to just say a few introductory words about this new initiative that we are starting, the virtual SACME Virtual Journal Club. We do have a minute left, so I will leave that minute to give the others opportunity to log in and see how many folks. I know that there were maybe 38 of us who signed up originally, but since we did reschedule this session, some of our colleagues had a conflict. So let's give it a minute to everybody to be able to join. We seem to have lost the screen for a second. Okay, here we go. We are back. And let's see if we can get that going. All right, so again, good morning, good afternoon, and welcome to SACME Virtual Journal Club, session number 1. I'm very, very happy to welcome you all to this first session of our Journal Club. As many of you know, this has been in the making and in the thinking for quite a while, and I'm thrilled to be able to share this session with you, our colleagues, and I really want to thank the group of enthusiasts who have come together and volunteered their time and their expertise to put this effort forward for us. The idea, as I said, for the SACME Virtual Journal Club has been forthcoming for quite a while. We have thought about the format that would work well for us, created a website, and it's really my role as on behalf of the program committee for SACME to welcome you all, to orient you in a minute or two, and then we'll turn it over to the presenters. So very quickly, this is a member benefit. You have to be a member in order to participate. As you know, you had to register for it. The way that you can participate is really through the website. Primarily, there are several links in the member section. So I point you that way. This is where you will see the calendar, you will see the topics about the topic, you will see the journal articles posted that we are going to be discussing. We currently have 2 sessions posted, the one today and the one in May, so it's May 29th. The times that we meet in virtual live environment, webinar environment, will always be Thursday, the last Thursday of the month when we have the session at noon Eastern time. Our time is scheduled from 12 to 1, so 1 hour. We already decided that if the discussion is very good and you have time, we will carry over. We won't stop at mid-sentence. So keep that in mind. We would like to let you know that there is a discussion area. So once we finish this opportunity to come together and in our community of practice in a webinar environment live, we can take the discussion over to the website and carry it on there. My hope is that we will be exchanging resources and contributing to topics discussed that way as well. I do want to point out that this session is going to be recorded. So for those of us who could not make it, there will be a podcast available of every session. So as without much further ado, I do want to say that you were sent guidelines on how to use this resource, and just want to make sure that everybody is comfortable participating. The goal is really to, once the articles are presented and discussed by the presenter, that everybody will be comfortable contributing. 2 of my dear friends and colleagues were kind enough to volunteer their time and effort, as I said, today. And I do want to introduce Dr. Kurt Olson, who really doesn't need much introduction. As you know, he's the Director of Research and Evaluation at Dartmouth. He is also Editor-in-Chief of our journal, JSEP, and has agreed graciously to facilitate all of the webinars in our journal club. So with that, I want to turn it over to Kurt. Thank you.
Well, thank you very much, Mila. Just a few things that I want to touch on before we begin. How we're going to structure the time is to give our presenter, Dr. Barnes, who I'll introduce in a moment. Barbara will be presenting the first article, posing some questions immediately following. We'll go on to discuss the second article following Barbara's presentation of that item. And then when Barbara has completed her part, there will be a more wide-ranging discussion that I'll facilitate that will address other dimensions of the articles that were selected for today, as well as trying to make connections with other things in the literature. So as Mila mentioned, everyone should have the participant guidelines. If you don't have it in front of you, where you can find it is in the email message that you received recently about the details of the call. Just a couple of things that I want to highlight from that. It's better if you're not using a speakerphone, use a handset or a headset instead. If you have call waiting, please turn that off. Avoid putting your phone on hold, especially if you have music that plays in the background, because we'll all be able to hear that if you happen to be unmuted. For that, you can leave your phone unmuted. That's controlled from our end. So if you want to comment, you will need to let us know so that you can be unmuted. And the way to do that is to raise your hand using the button for that purpose that you'll see. Now the button's a little bit counterintuitive. It does not tell you the status, but rather the action that you want to take. So if you see a green arrow going up, click on that to raise your hand. Red arrow down, click on that to bring your hand down. So if you want to make a comment, as part of enter into the discussion, raise your hand, and I will do my best to make sure that everybody who wants to can get into the discussion. If you have a question that comes up as Barbara is presenting, you can send that to me in a text message within the as part of the chat feature in this webinar program, and I'll relay that at the first opportunity. Participant-to-participant discussion is encouraged, so if you hear a comment from one of the others that you want to speak to, just make clear that that's what you're doing. That not everything has to be between the presenter and the individual participants. So we're really hoping to simulate as much as we can kind of a freewheeling discussion that we might have if we were all sitting around the same table. One last thing, remember that the primary goal is not to critique the article and the methodology, but rather to engage in a discussion about how the article relates to our practice and to theory in the field. So that is the aim. Well, with that as background, it's my pleasure to introduce Dr. Barbara Barnes. Barbara has a distinguished career in the field. She received her medical degree at Pennsylvania State University, Penn State. She's board certified in internal medicine. She is currently Associate Vice Chancellor for Continuing Education and Industry Relationships and Associate Dean for CME. So in that role, she coordinates continuing education programs for all 6 of the health sciences schools, but specifically oversees the CME program for the School of Medicine. And she is a past president of SACME and someone that has been a major contributor to the field. So with that, I will turn it over to Barbara.
Thanks so much, Kurt. I'd just like to emphasize that this is really an experiment, and we very much value your input into not only the content, but the process for this journal club and the technology. We're all still fairly new with the technology, so I hope that you will all bear with us if there are any glitches and so forth. But this really is to the credit of Mila, who has tried to look for creative ways to serve the needs of the membership, and I think represents a very exciting opportunity for us to get more engaged in the literature and learn from one another. So I was asked to select a couple of articles that might be of general interest, and I think we all struggle with trying to develop more interactive types of learning activities, and also obviously trying to achieve higher level outcomes from our activities. And most of our programs do have some component of simulation, whether we certify it for CME credit or not. And we all recognize that this is very well received by the participants, but it's also very resource intensive. So after seeing an article in JAMA in December, I thought this might be a very interesting topic for us to spend a little bit of time discussing. Jim, could you go to the next slide? So just in terms of general background in this area, there are a lot of different types of simulation methodologies with a range of what is called fidelity, which really represents how closely the simulated environment matches the actual clinical or work environment. And again, most of our institutions have devoted a lot of resources to this and are very proud of what we do. But there are not a whole lot of outcomes or critical analyses of simulation, and particularly not in areas that go beyond medical knowledge and clinical care. So we're, I think most familiar with, typical skills training where we can assess competence immediately after the activity. But we all struggle with how to teach the other 4 competencies, particularly things like communication skills that are critically important, particularly in the emerging healthcare environment. So, it's, as I mentioned, been assumed that the more closely you can emulate the clinical environment, the better the outcomes of simulation are going to be. So the 2 articles that have been chosen do represent these kinds of studies. Jim, can you go to the next one? So I decided to select 2 studies on this topic of use of simulation to improve communication skills, and thought it would be interesting to look at articles that use different methods. So the first is a more classical randomized controlled trial. The second is a qualitative secondary analysis. As I mentioned, the Curtis trial appeared in JAMA late last calendar year and really attracted a lot of buzz. It actually generated an op-ed piece in the New York Times, and I thought it would be particularly interesting to discuss since it probably reached a lot of your faculty members, and it might have been something that you heard about through them. And then the second, representing what is an interesting secondary analysis using qualitative techniques. So as I mentioned, one of the things that we want to do today is to explore the technology that we're using for the format of the webinar, and one of those functionalities is a polling device. So we'd like to take a poll of our participants. So Jim, you could bring the poll up. And I'll say that this will be anonymous, so nobody has to fear being honest with this response. We were just interested in whether you read both articles, only one or the other, or neither article. And if you could go to the polling feature and respond, that would be great. And Kurt, would you just like to be sure that you explain the polling feature?
Oh, well, my understanding of it is that you just simply click on your answer and then hit submit. I say that because I'm not able to do that as the facilitator. So I see the window, but I'm not able to take action. So hopefully that's how it will work for you, and we will give you the results here in just a few seconds.
And we should also say, if you have any specific questions, you can submit those, and Kurt will be taking a look at those, and we will respond.
So, okay, nearly everyone has voted. We're at 94%. Any last votes before we close?
Okay, you want to show the results? Great. Terrific. Thank you, everyone. You get bonus points for terrific preparation. So, Jim, you can go to the next slide then. And the next one. Great. So as you know, having read the article, the Curtis publication was in JAMA in December of 2013. This was in their annual education issue. And this was an attempt to understand the impact of a role play involving simulated patients and families and clinicians to improve communication skills in dealing with end-of-life issues, which is obviously an extremely important area. This was an extremely intensive intervention that was carried on in 2 institutions over several years, involving 32 hours of exposure. And this was based on a prior study demonstrating that there was immediate post-intervention improvement in the standardized patient assessment of communication skills. The participants in this were, residents and nurse practitioners from 2 institutions, so interestingly 2 cohorts of health professionals. And the design was a non-blinded randomization, also with blinded evaluators. So as you saw by reading the article, again, this was a fairly large, intensive, and fairly classically designed study. The primary outcome measure was the quality of communication as assessed by a questionnaire pre and post. And the secondary outcome was actually a much higher level outcome, actually a patient outcome, quality of end-of-life care that was actually delivered. And this was assessed both in terms of depression and functional status. Next slide. So the results, this was actually, as I mentioned, a very large initial cohort of 1,068 physicians and nurse practitioners. 472 were randomized with about equal allocation to both groups. 406 completed, and a little less in the intervention group than in the control group. The cohort was mostly physicians in training rather than nurse practitioners, and largely physicians early in their training, with somewhat overrepresentation of women. I think somewhat of a surprise to the investigators based on their pilot project, there was no significant difference in the quality of communication from the intervention, except perhaps for patients with poor health status. And again, this was evaluated based on questionnaires, and the secondary outcomes. Actually, the patients who were part of the intervention group actually reported more depressive symptoms rather than what one might have expected, and no significant change in their actual functional status. Next slide, ma'am. So some of the things that the study raises are that, again, this was an extremely resource-intensive intervention. Over half of the potential participants weren't interested in participating in the study, so whether that had to do something with the resource intensity, and whether there was a self-selection process for those who were particularly motivated or had a particular interest in this issue. There was a considerable drop-off in terms of getting evaluations. These were actually evaluations by preceptors and instructors, so challenge that many of us have, and obviously the concern that they really couldn't identify any significant impact from the intervention in terms of the higher level outcomes, in terms of the actual assessment of their communication skills with patients at the end of life, or actual functional status or depressive symptoms in these patients. So I think this might be of some surprise to us, perhaps, and we wondered about your thoughts. Is this something that you would think is unexpected, that they put all of this work and intensity in the study and they failed to demonstrate any kind of higher level outcomes? And Kurt, maybe you could just initially comment from your perspective.
I think it's challenging at two levels. One is to actually have an influence on clinical practice. Another is to get an accurate measure of what's taking place. But I'm really interested in hearing what the participants are thinking about the question that you posed. So if you would, if you want to comment, please raise your hand, and I will unmute your microphone. So we need someone who is willing to venture out and offer their view.
And I guess I maybe could ask a more direct question in terms of designing this type of study. Do you think that it was actually realistic to even expect that there would be these types of outcomes from this type of intervention?
Mm-hmm. I see that David Price and Dorothy Lane have their hands up, so I'm going to start with David.
Great.
David, you are unmuted. Can you?
Maybe audio ping.
Yeah. David, we're having an audio problem on our end. We're getting sort of a Alvin and the Chipmunks sound from your phone, unfortunately. So while you're puzzling that through, I'm going to unmute Dorothy and give her a chance to comment. Dorothy? Dorothy Lane?
Dorothy?
Nope, no sound there. And I can see participants who have muted themselves, and that is not the case here, so I'm not sure what the problem is. Sorry for the difficulty, Dorothy. Let me try David again. So I'm muting Dorothy, unmuting David. No, sorry, David, same problem. So I've had to mute David again. Someone else want to give it a try? Okay, Bill Defoe, I'm going to unmute you. You should be on.
Hello, can you hear me all right?
Perfect.
Yes.
Oh, excellent, good. It's interesting. What it reminded me was of a study that was done many years ago by Nancy Fraser-Smith at the Montreal Heart Institute. And in that study, she had very well-trained nurse clinicians go out and counsel elderly women who had had cardiac problems. And the thesis was that all of these women would improve. But what actually happened is that they actually got worse. And some of the hypotheses, although it wasn't really known, was that perhaps these elderly women who were living alone now felt worse because now they were aware of, you know, their problems, and they saw these young, very healthy nurses. So it may be, you know, I don't know if there's anything similar here, but that's what it reminded me of.
That's very interesting. I think one of the other aspects of this study that was of some concern was that the evaluations were done by a lot of different individuals in different institutions, and in some cases the evaluators only evaluated one of the participants in the study, and it was not clear at all exactly you know, what the qualifications were of the evaluators or what the reliability might have been. And Kurt, you brought up a very interesting study in terms of paramedics who were observed administering CPR, and some of them were inexperienced, and one in these video vignettes had long experience. And these vignettes were shown to three groups of subjects: paramedics with practical experience, students being trained in the field, and instructors in life-saving techniques. So this is, I think, you know, somewhat relevant here in terms of doing a study like this, and you know, what would we be looking for in the evaluators. So in the case of this study, you know, it would be similar to the second category. So in terms of seeing the validity of the evaluation that's done by these groups in terms of whether they could pick out which one of the 6 in video vignettes represented the most experienced paramedic. We wondered if you had any guesses at which one of these 3 groups might have been most accurate in terms of identifying the most competent individual. Yeah. So if you would want to respond and take your best guess on the poll.
Yeah. Now, just to clarify, so again, the situation was there. These folks were shown 6 videotapes of people who were demonstrating these techniques, 5 of whom were trainees, 1 of whom was a highly experienced paramedic. So the question is, so they were asked, who would you like to, who would you want doing CPR on you, if you were the patient, and they were to choose from among the 6. So who would be better able to pick out the most experienced, accomplished person out of the 6? Would it be the students, the instructors, or the experienced paramedics? Okay, so we're at about 2/3. Anyone that wants to vote, now's the time. Okay, so here are the results. 7% of you said the students, 14 the instructors, the remainder said the experienced paramedics. So if I could, what I'd like to do is ask those of you who chose these different options to find out if you'd be willing to lay out the rationale. So what would be the logic that would suggest that the students would be best at recognizing the most skilled paramedic? So if you care to speculate about that, you have a theory, an idea about that, please raise your hand.
Or even any of the 3 categories, probably.
So for any of these choices, what would be the what might be the rationale for any of these choices?
And so our traditional approach would be to say that the instructors would be the appropriate ones to evaluate the students or the expertise that they, so what they do. They are the accomplished people in their field, and have the academic background, and that is the traditional model that we use in education.
Yep, yep. Bill Defoe would like to comment.
Yeah, I chose the experienced paramedics. I would think they would be probably almost a summary gestalt that people would be looking at the kind of the efficiency, the confidence, and there'd probably be a number of different clues that would come into that decision. But again, this is just a hunch on my part.
Any other thoughts? Kurt, do you want to talk about the results of this?
Sure. This is right. You all came up with the right answer, so to speak. The 90% of the experienced paramedics picked out the right person out of the 6. The students were correct only 50% of the time, and interestingly, the the instructors were least successful at picking the experienced person only 30% of the time. So this was part of a study that led to a good deal of work by Dreyfus and Dreyfus, who you probably recognize as two people that came up with a model of how physicians develop expertise as they move from novice to expert. So, I mean, there are many different reasons why the people who did this, the study that Barbara was talking about originally, might have observed that standardized patients were scoring performance at a level that indicated there were significant gains, but the patients were not. What, if anything, do you think this, the example of the paramedics has to do with communication in the context of nurse practitioners and residents?
And I would just say that I think, you know, the example you gave in terms of the CPR vignettes is even more straightforward than the situation we were dealing with in this particular study, in the Curtis study, given that, you know, different individuals may perceive different characteristics in communication style. So, you know, having a greater diversity of evaluators might even be more problematic in this kind of setting.
Mm-hmm. Mm-hmm. Okay.
So should we just go on to the second article, and then maybe we can have a more general discussion in the context of both of them?
Very good.
Okay, Jim, why don't you go to the next slide then? Okay, so the second study, as I mentioned, was actually a qualitative study on medical students, and this was in Great Britain. These were three studies of longitudinal problem-based learning using simulated patients to train on and assess communication skills. Schools performed interviews following actual patient encounters in year one, as well as encounters with standardized patients. So this was interesting in the sense of actual getting feedback on the experiences using standardized patients in simulated setting versus the actual patient encounters. Jim, could you go to the next slide? The results of the study indicated that the students had a high level of satisfaction with standardized patients. The simulation was felt to be very useful for skills acquisition, but some concern was that the students didn't necessarily feel that the training in the simulated setting well prepared them to function in the actual clinical environment, that there were certain elements that were not present in the simulated setting that they needed to deal with in the actual clinical world. But the students really appreciated the positive feedback that they received in the simulated environment. However, they also felt that it was somewhat artificial, and that they were performing, you know, sort of for the test rather than what may actually happen in a much less formal environment, given that the actual patient encounters were actually much more unpredictable and also that the preceptors did not give them the same level of feedback as in the simulated environment. Next slide. I thought that Yardley came up with a very nice theoretical model in terms of what they call the fiction contract on difference between this very well-controlled artificial simulated environment and the many variables and factors that are present in the real world, and acknowledging that both of these settings are neither perfect nor good or bad, and that there is a lot of merit of understanding the differences and informing the education based on the experiences in these two environments. And I think this speaks again to the Curtis model study, where obviously there's high satisfaction and good improvement based on the feedback from these standardized patients, but not well correlated with what actually happened in the clinical world, particularly in a very challenging area of end-of-life care. So you can go on to the next slide. So this really, somewhat raises the question about whether we should try to create a high-fidelity simulated environments. Whether we should spend a lot of time really trying to emulate what happens in the clinical environment, or if we should think about the core skills that we are trying to train best in the simulation world, and then understand how we can then apply that when students and physicians are actually going into the clinical setting. And how we design realistic outcomes. In one way, we're pressured to look for changes in competence and performance and patient outcomes. But how can we be realistic about that when we are doing work in our own environment? And also, how can we better coordinate along the continuum of the traditional learning environments and those that are much more intensive and much more complex. So, Kurt, do you want to take us into a more general discussion based on both of these articles?
Sure. Before, I'd like to ask some specific questions about this one, which I thought was a very interesting paper. This concerns what the authors and why they were worried about the lack of understanding about the gaps between med students' experiences and simulated and actual patient visits. I mean, clearly they thought this was worth studying. Why did they care about that? What was your sense for what was driving their concern about the lack of understanding? See, I see Lauren has her hand up.
Can you hear me?
Can. Yes.
Yes. Oh, good. Okay. I think they were concerned about the students were then comparing and contrasting the two experiences, and then making value judgments on the knowledge that they were gaining from the simulation versus the quote-unquote real world.
Mm-hmm.
So that was their motivation for really identifying, how can we address this issue of students coming away from this by kind of discounting the simulated environment versus the real world environment.
Right, right. So the idea is that this would be learning opportunities missed, or discounting, as you said, the value of the simulated experience over the more real-world experience? Mm-hmm.
Yeah, I like that concept of the value judgment in terms of, sort of diminishing the benefit of simulation rather than recognizing that it is a different environment and wouldn't necessarily be expected to translate into the real world.
Mm-hmm. Now, the authors propose a way of thinking about that gap, a way of responding to that gap in a way that would enhance students' learning. What was their proposal, and what do you think about that? Let's see. Milo, you have your hand up? Was it in relation to that question or something else?
Sort of to tie between the last one and this one, I think one of the biggest issues, and I'm speaking from experience because we've done high fidelity training in communication using SPs where it worked really well, and we have done patient health outcomes in a segment of our trainees looking at patients. We did qualitative studies, we did semi-structured interviews with trainees as well as the subset of their patients, and found different findings. So I think that what the authors recognize here is the importance of the context, which was missing, it sounds like, in the original scenarios, SP scenarios, and then the idea is that needs to be brought in to amend the process. And to use what's really good with using standardized patients, and even the students and everybody pointed out to the value that of the SP feedback, and that's something unique to this technique and is great to practice with because you rarely will get that level of candor in a real environment. So using that, combining it with other techniques that we know work well, such as having a really well-moderated and facilitated session where there's a value to pausing and freezing the suspend belief in the scenarios and engaging the peer group in providing feedback is also something that will strengthen the value of the SP training. Mm-hmm. But ultimately, I think it hinges on, going back to the Dreyfus and Dreyfus, it hinges on the context of experience that a learner brings into the training environment. And that is the question of where are we at that novice through, moving novice through, advanced novice all the way through proficiency, competency, and the mastery level. And depending on that, obviously the feedback and the value perceived and received will be very different. Mm-hmm.
Other perspectives, either building on anything that Mila had to say or otherwise? Bill, you're now unmuted. Bill Defoe.
It's me. I'm sorry, can you hear me?
I can, yeah, go ahead.
Yeah, okay. It strikes me that it's interesting that we often don't hear the same criticism from our trainees when we do kind of mock orals. Now, maybe they feel reticent to criticize the staff, but when you pose some of these scenarios, and in a sense, you're somewhat of a standardized patient. So I guess what I'm wondering is, there are standardized patients, and then there are standardized patients. There's different levels of training and credibility. And I just sent this question in, but for example, if you actually have real patients who have a bona fide history and physical findings, and yet they're coming in weekly or so to see medical students, they often are kind of in the middle. They're not kind of the actors, but they they actually do have perhaps there's a higher credibility factor there. So.
Mm-hmm. So do we know from the description in this study what was the case in this particular study?
For the standardized patients, I don't recall seeing anything about the training or.
No, that was not specifically addressed in the paper.
Yep. Yep.
But I think you raised a very interesting point in terms of, longitudinal experience for students and, even for practicing physicians. When you do have continuity of care, it gives you, a much better opportunity to, try to develop communication skills that are appropriate, and particularly in the training situation, to have consistent feedback on those patients. And it's certainly a limitation of the Curtis study, where there was no indication as to ongoing follow-up with those patients. That, and based on the low response of the patients, probably there were very limited or short-term interactions with many of them.
Another interesting thing, I don't know if you can hear me. Can you?
Go ahead. Yep.
Mm-hmm.
For me, there was very little discussion in both of these when they referred to more traditional training as opposed to the intervention studied. That was never defined. So
right.
In the first paper, in the Curtis paper, I wondered what that might look like.
Yes.
I'm assuming it's a didactic, but what is it? I mean, to do an RCT validly, you would need to have the same curriculum at least.
Right. And Michael Schoen had raised the same question in a text message. What happened in the control group? I couldn't tell from the article.
Yeah.
Mm-hmm.
Yeah, that was not described in either article.
Right. It was completely glanced over.
Mm-hmm. One way of thinking about the recommendation is essentially to help med students, in this case, reframe how they think about the discrepancy between what's going on in the simulated environment and what's going on in the clinical setting, and do that in a way that increases the likelihood that that becomes a positive, that it's seen more as an opportunity, a resource for learning, rather than a problem to be solved.
Mm-hmm.
I'm curious about what you thought about that. Is that something that we do in other circumstances, something that you do?
And whether we should be taking time during these simulated experiences of talking about the translation into actual practice, and what some of those barriers might be.
Mm-hmm. Bill, you have your hand up.
Yes, this topic came up with my first year students for clinical skills. And we traditionally, use the standardized patients first of all, and then migrate, to seeing real patients, either as outpatients or on the wards. And the discussion was that, they initially got somewhat frustrated with these quote-unquote actors, but then when we actually talked about the point you're making, Curtis, that what were the learning opportunities, and the advantages and disadvantages of the different types of patients, or real and whatever. And then they, I think once there was more clarity there, then they could also then choose, let's say they had to have a dedicated review of the neurological exam, then they might actually choose a standardized patient. So I think it's actually looking back on it, perhaps we should have had more of a discussion, like this earlier on, and might have saved some frustration.
Yep. Now, to this point, the focus has been on med students, residents, and nurse practitioner trainees. I believe that's accurate. How do you see either of these studies relating to continuing education? How relevant are they? Are the issues that are raised less prominent? Are they more prominent? What do you see as the relevance?
And I would add, particularly when we're designing outcomes measures for our activities, and we assume that, more realistic and engaging and interactive activities are going to be having higher level outcomes. Is that realistic in view of this work?
Well, if this is Mila, if we think about the audience that we work with, which is practicing physician or practicing clinician or teams of practicing clinicians these days, the importance of the context that they bring with them and their real life experience is something to keep in mind, and how that's different from the novice and the trainees that were subjects of these studies. And designing education, I think what's important, for me, what this brought home is that not to lose sight of that aspect and to really design education for the appropriate level of experience and context. And I don't think it's a question of negating the interactive nature of these techniques, but rather paying more attention to that in order to do better. And I would certainly think that we don't want to throw the baby out with the bathwater based on these. That would be my 2 cents.
The New York Times op-ed piece that spawned from the Curtis article was interesting in the sense that a physician attended a communications training program, and the person who led it was very proud that he had really improved his communication skills as a result of attending one of these training programs. And the person writing the article was commenting that the facilitator, had a very scripted communication style and really a very non-authentic kind of approach, and commented that we have to be realistic in terms of, how much we can change established behavior and current communication patterns. So I think that speaks to your point, Neil, that, is a little bit different situation when we're dealing with practicing physicians, and also with some of these softer skills like communication. There may not, be one right answer.
Actually, there's evidence, 3 points of evidence on this from the studies that's validated that there are 3 areas of communication that are very important to bear in mind, and that's what we approached it when we started developing a curriculum in communication for practicing physicians. We went out to scour the literature and see what's the evidence behind this kind of training at all, the effort. And it turns out that I can send everybody the slide in the follow-up, but it turns out that first of all, you can do a great damage with bad communication skills in terms of patient outcomes, especially in adherence. Secondly, you can do good if your communication, there's evidence for that, if your communication skills are good. And thirdly, and most importantly, is that this is a teachable skill, so that we can do something, you can improve with it. So I'll be happy to share those references with the group.
Mm-hmm.
But I think, that's something that that we grounded our training and,
Mm-hmm.
and the effort.
Yep. And Bill Defoe, you've been waiting patiently to get in.
Well, that's fine. Yeah, no, I agree with the comments. And when I think of the physicians that take our SACME programs, they wouldn't be tolerant of somebody just kind of being an actor. On the other hand, I think when, some of the best workshops are when skilled physicians or nurse practitioners are also very good at role playing, and the edges get a little blurred, in terms of in some very good workshops, when in small groups, of course, people take on different kind of role playing skills. Not everybody welcomes that, of course, but I think by doing that, it's just another modality of kind of learning. So I think for CME, it has to be done in certain ways if it's really going to be effective.
Yep. And I think going one step farther outward, so to speak, what I see this as the second paper as being about is how do we help learners get into the mindset, into a mindset that is going to optimize their learning. And so it can be as simple as showing a video, for example, and saying before you begin, to pay attention to these things that are going on in the video. So helping people bring a frame of reference that will help them get the full advantage out of the experience that they're about to have. And so I see the the recommendations from Yardley et al. As being very much like that. How do we prepare, how do we work with, how do we coach students in these situations so that they bring a something other than a problem mindset to those differences. So, well, I see that we are at the top of the hour. I think I also see that at this point there are no hands up, so there appears to be no one who is waiting to get in with a comment. So, Mila, do you have any closing comments?
Thank you, Kurt, and I do want to thank Barbara very much for her effort, both of you really, in doing a very thoughtful and thorough job with a selection of the articles and preparing the discussion. I do also want to thank our participants for being patient with us as we, like Barbara said, struggled a little bit through the technology piece, trying to make the best of it and trying to make it interactive. So I apologize for the audio snafu. We hope to get better. I do invite everybody to please continue the discussion. I know it's not always easy to talk in a group, but maybe the online forum will provide the opportunity for you all to bring in your points, to share resources, some evidence from your practice, because after all, as Kurt pointed out, the goal of this series is to look to the literature as evidence to inform our practice, and then see how we can translate it into what we as practitioners in continuing professional education are using and can be contributing. And also I do want to thank you and say that we have prepared a bit of an evaluation that will be coming to you as soon as at the conclusion of this session. And I do ask you to give us your feedback, because that's the only way that we will know how to improve and move forward. We want to know if this was useful to you and what other ideas you may have. We also will connect this to another survey in the domains in terms of the needs assessment of the journal articles you think would be useful to you. And I do want to invite everybody to contribute. When you're reading literature, think of the areas that you think would be of interest to others and that you may feel confident and would like to present. So there is a editorial board form that will be looking at these proposals. and I really hope that you will all participate. Thank you so much.
Thank you, everyone.